One of the people who was instrumental in developing the term OAB was Wein, and I'd like to ask Alan to come forward and give his views on OAB, the good, the bad and the ugly. Alan is well known also throughout the world and into the society. He's professor and head chair of the Division of Urology at the Pennsylvania University. Alan, thank you.
Thank you. It's a pleasure to be able to participate in this debate in honor of a really good friend. Norman was a guy that you could disagree with, but never fail to love, and you could disagree with absolutely no hint of dislike. He was that kind of person. So it's my task to tell you about overactive bladder, the term, and then duck, I guess. Here are my conflicts. So, what's good about it? Well, this is how it started. Paul Abrams and I were asked to organize a conference in 1977 on a topic that was entitled the unstable bladder, which is a term that I like even less than the overactive bladder because that was the name at the time. So we asked that we be able to entitle the conference something else. They said, well, what would you like to entitle it? We thought about it, and based on all the factors at the time, we came up with the name overactive bladder. The definition was formalized in '99, and the ICS formalized it in 2002. This is the title page from the journal Urology, where the proceedings of the conference was published. Now, what were the original goals? Well, these were our original goals anyway. Describe a common condition, not a disease, in a term that was primary care provider and specialist friendly, a term that would allow initial non-invasive treatment with no complicated or expensive or invasive studies, and include a laundry list in the simple evaluation that was necessary so as not to harm anybody. So hematuria, pelvic pain, etc. That was a couple of things on the laundry list. So overactive bladder is not a disease, it's a symptom syndrome. It's a combination of symptoms. And this is the formalized definition. Urgency, with or without urgent incontinence, usually with frequency and nocturia. Here's one of the hookers: in the absence of an underlying metabolic or pathologic condition. Now, the first thing that comes up is, well, if you're going to say that you have to have urgency to have this symptom syndrome, which can include other symptoms, what is urgency? These are the two ICS definitions. The 2002 definition is fine. As you'll see in a minute, I think probably we never should have left out for fear of leakage. Taking out for fear of pain was fine. I put in a couple of Chris's diagrams so he at least couldn't criticize me. This is what the normal micturition process looks like, and this is obviously what urgency does to it. It shortens the inter-void interval. Sometimes you have incontinence and sometimes you don't. Okay, well, what's bad about it? Well, all the arguments about urgency. Is urgency a continuous or dichotomous variable? Is this important? I'm not sure that it's important. Is urgency all or none? That's a great question. The question never would have come up had it not been for this definition, by the way. Are there grades of urgency of different severity? I like Chris's rheostat analogy that I'll show you in just a minute. Obviously, when doing clinical trials, if urgency is the primary symptom, it's the thing that you would like to measure. But it's the thing that's the most problematic in objectively measuring because it's the subjective symptoms. And the ICS definition is very unclear when it has to be translated into an unequivocal form that the patient can really understand. And I think we should have left in the definition for fear of leakage. This is Chris's analogy, which I like very much. Is urgency the presence of a sudden compelling desire to void? Is that like a light switch? It's either all on or all off. Or is it like a light switch with a rheostat, where it can be either mild, low light, or high, very bright light, or some combination? I mean, my personal opinion is that it can be truly episodic. You have it, you don't. Or it can occur as the final sensation following a gradual buildup of the urge to void. But I think there's a definite point where urge, which is a normal sensation, turns into urgency, which is not. I think that the urgency actually is episodic, but like Chris's rheostat, it can vary in intensity, and that does permit grading. These are ways that actually Marcus Drake and Paul Abrams describe that urgency could be best expressed to patients. And I think that this is very useful when thinking about a study or thinking about trying to grade urgency or see whether it's present or not, because I think that these three are about as good a way as you could ever describe. So what's wrong with the definition? Well, there are lots of things wrong with the definition. Does that make it all bad? I don't think so. First of all, the term urgency as the sine qua non eliminates what we used to think was a pretty good term called reflex incontinence. In other words, incontinence that occurs because of a detrusor contraction without sensation, like in a complete spinal cord injury patient. To me, there's no evidence at all that that is much different than an involuntary bladder contraction with sensation, except there's no sensation. So I'm not sure why the two are separated. There are a fair number of geriatric patients who have leakage due to involuntary bladder contractions without sensation. So according to this definition, they're not included. I think that's ridiculous. The whole issue about the exclusion because of known pathology, infection, carcinoma, etc., everything here, and probably benign prostatic obstruction for those people who think that obstruction is associated with overactive bladder and actually a causative factor. I think that that fits in well because really the symptoms are the same and the non-invasive treatments are the same. So the only thing that's different about those is that there is a direct cause that you can treat as well. So I think that the term overactive bladder is certainly not perfect as long as you remember it's not a disease. And those who have tried to make it a disease, I think, are dead wrong. If I were going to change it, I would simply change the categorization. Overactive bladder that's definitely due to a neurologic cause. Overactive bladder when you can't find a neurologic cause, but is due to an identifiable cause, like carcinoma, like urinary tract infection, etc. Those are presumably reversible. And those that are not due to a neurologic cause, where there is no identifiable cause, recognizing that the boundaries aren't discrete. So have at it. Norm, thanks for the opportunity. I appreciate it.